everyone, and welcome today. For those of you who have absolutely no idea who I am, my name is Nick and I am the founder of TRUK, also known as Trauma Research UK. For those new group members who have recently joined our group, welcome. And you've joined at a really exciting time. So now moving forward, we are going to start introducing videos and interviews just like this one as an alternative means of support for our group members. So today in this video, I'm going to be looking at trauma-informed care in practice, inclusive of trauma-informed therapy and how it's used within the UK. I know that we have a couple of US members, but our situation in the UK with healthcare at least kind of greatly differs from the US. So this is more geared towards the UK. Today we're very lucky enough to be joined with Sharmi. Sharmi is a practitioner and psychologist at Stepping Psychology, which is a trauma-informed care and therapeutic intervention. Hi everyone, and I'm really glad you could join us. Today we are going to talk with Sharmi from Stepping Psychology on trauma-informed care and trauma-informed practice with the look at trauma-informed therapy. So welcome Sharmi.
Thank you.
Really nice that you could join us. And if we could just start a little bit by you just giving you a little bit of an introduction and a little bit of background about who you are and what you do.
Sure. Thank you. Thank you for having me, Nick. Yes, so like Nick introduced me, I'm Sharmi. I am the founder and clinical director of Stepping Psychology. I am a trauma survivor myself. I do have a diagnosis of complex PTSD as well. My background is in psychology with a specialism in trauma and attachment. I have worked in NHS, both in adult mental health and in camps. I have also worked in the private sector, counseling services, but past 5 years, I worked in a trauma and attachment specialist clinic, working with children who are either adopted or in foster care or in any sort of looked after services. Along that, I had my own private practice, that's Stepping Psychology, but I didn't focus much on that because I was working in this other clinic. Recently, I have left that job and focused on my own private practice. So that's what I do mainly, and it is a specialist trauma therapy service.
And am I right in saying that your Stepping Psychology is completely trauma informed?
Yes. So it is completely to do with supporting trauma survivors, and every treatment or therapeutic approach is with trauma in mind.
Brilliant. I really feel like that's an important way to go forward. Instead of like maybe having a blanket approach of CBT, which we will go into later, I really feel like what you're doing and what you're providing is absolutely amazing. So well done you.
Oh, thank you.
So a lot of our members in the group that I run, Trauma Research UK, they have a confusion between the diagnosis between PTSD, CPTSD and developmental trauma. Would you be able to sort of elaborate if CPTSD is recognised now? Or
Yeah, so even with complex trauma, people often get confused. They think, is complex trauma and developmental trauma even the same? So developmental trauma, like all of them have some sort of overlap, but if you really have to put them all in their own box, how to explain this, developmental trauma means it's through your developmental stage. So it can be not even at birth, but even prior to birth. So if the mom is alcoholic, or she might have carrying her own trauma, even from that stage till the child grows up, so the whole developmental stage. And it doesn't always have to be childhood trauma, as in something happened at home. It can even be being bullied at school, or having some really traumatic thing happening to them outside home even, that can be developmental trauma. That's usually childhood trauma. When people say childhood trauma, they more think about some trauma they probably experienced within their home. Maybe it might be lost. They might have one of the parents might have passed away, or they might have experienced violence and abuse, or even witnessing that. Or the trauma we never really talk about, or rarely talk about, or think about, is is the subtle ones, emotional neglect.
Yeah.
Because I think that's the one people really struggle to identify, because they think, I do struggle, but I don't really think it's trauma. And the reason people say that is they think about this dark, gritty things like childhood sexual abuse or violence, but don't really think about emotional neglect.
Well, I find that even with the use of the word trauma itself, it carries presumptions, for the general
Mm.
public. If you say, well, I've had trauma, they think, oh, you've been to war.
Yeah.
No,
Yes.
it can be even as subtle as, babies getting medical procedures to save their
Exactly.
life. The body recognises that as
Mm.
trauma, but, the mind is like, what's going on here?
Exactly.
Would you
Exactly.
say there's a sort of category for CPTSD now than where there wasn't before?
Yes. So I've seen a change in that, which is really positive. That
Yes.
I did when I was doing my doctorate training. That was my research around CPTSD, and I remember when I was looking at different resources. With even NHS, I looked at mine. There was nothing worse now. That if you go on mine's website under PTSD, it says complex PTSD as a separate section for that. Same with NHS, nice guidelines, so there's definitely more recognition, whereas before it was more perceived as a made up diagnosis, whereas now I think clinicians are embracing that terminology, which is good, because that means that there's more of increased awareness, which means
Definitely.
there will be better treatment available.
Yeah.
Yeah. But you ask about the difference. So again, complex trauma generally speaks about when there haven't been one single trauma. So it's not to dismiss or minimize that. It's not to say, oh, you have only had that trauma, mine is more complex. That's not what it is. It's more to help understanding how to treat it, or how to give intervention. So you can separate the two, right? Single
Yeah.
trauma. Um, I don't think people really use this much here in UK, but in America they call it the big T and small T. So
Okay.
small T means that everything was fine, you were fine, you coped okay until the moment you had a trauma. So that could be, say, a car accident.
Yeah.
So that's a single T. Whereas small T, the big T is when actually you can't even recall when things were safe. So that's probably where complex trauma comes in, because it's complex, it's multiple, usually it's chronic, repeated, all that. So you can see it's really complex. So you have to think about all this when you are giving treatment or any sort of intervention or support. And that's why it's good.
What I see usually around about, say, like groups and things like that, is people saying they have a diagnosis of PTSD, but they then go on to say, my mum did this, my dad did this, and I grew up with X, Y, and all this sort of compounds.
Yeah.
I think to myself, I probably developmental CPTSD, and that really changes, because if I thought for myself, like, I had PTSD for so long, I didn't know there was anything like complex trauma,
Yeah.
even though I had experienced trauma from in the womb, in utero, and growing up repeatedly.
Yeah.
It's actually a really huge thing that they're now recognising complex trauma, and hopefully in the future developmental trauma will be added to the DSM-IV,
Yeah. Yeah.
and that would totally change the face of treatment.
Definitely.
Yeah.
Yes. So developmental trauma, again, like you said, like even when a baby is being formed, like at that time before birth, even there can be trauma.
Yeah, and we're just now starting to see sort of research come out about that,
Yeah.
which I find it fascinating.
Yeah.
So do you know, like, sort of how the NHS approaches the treatment to trauma, just in
So
general?
yeah. So again, generally speaking, it's more medication or CBT, EMDR,
Yeah.
which again I see that there's still a lot of work, a lot of work need to be done, but it's still a positive, because again, few years back there was not EMDR in NHS.
Yeah.
People had
Yeah.
to seek that privately. So I think slowly there is a change, there is a shift.
Yeah.
But again, the EMDR is really, really beneficial. I have had it myself. I have received EMDR, and I know that with my clients, I've seen like how helpful it has been. but also it's limited in the sense that EMDR was developed for single trauma.
Yeah.
It wasn't for complex trauma. It wasn't for developmental trauma. So it can help some, work on some parts of the trauma, but not all of it.
Yeah, I've seen that as well in research that I've read. The EMDR is really beneficial for single trauma and maybe block memories.
Yes.
I've never really been privy to have the benefit of receiving EMDR, because in my experience of NHS treatment, it was just kind of a blanket CBT approach that I received.
Yeah. And also EMDR has some limits in terms of rather than only looking at it, okay, you have had trauma, let's give you EMDR. Also really thinking about, especially like you said, if there have been developmental trauma, it's not only one. So just talking about all that, like just going into all the details, can be really triggering as well.
Yeah.
Whereas somebody with single trauma, that can actually be okay to access that.
Yeah, and it's great that we're now seeing sort of the differences between PTSD and CPTSD, or developmental and treatment, and how we approach it is now different.
Yeah.
Kind of provide us a little bit of hope that if things kind of progress,
Exactly.
Yeah,
exactly.
definitely.
I don't think people even really thought about or talked about trauma before, whereas now there is definitely a big shift now, isn't it?
Yeah, definitely a big shift. Would you say yourself that trauma-informed care is sort of relevant with the NHS, or is that something that individuals would need to seek themselves?
I think it's relevant because, again, I think when you think about mental health, often people talk about eating disorders. People often talk about depression, anxiety. Those things are very common, and the treatment is often from that sort of surface level.
Yeah.
Solving that problem rather than really looking at the deeper roots. And often the deeper roots are, if not all the time, most of the time, it is trauma. So it's really, and it's not only about the intervention, it's also about the message we are giving people seeking the help. Because if you see on a sheet, you receive, and there's this list of problems you have. You have eating disorder, you have anxiety, you have depression, you have borderline personality disorder. What sort
talking about me here?
Yeah, like the message you are getting is like, oh my gosh, like this is all me. This is all.
Come on, reset.
Yeah. Whereas just by changing that label, that this is trauma, it's a more gentle, compassionate, humanistic shift, isn't it? That it's not pathologizing the person. Instead, it's like, this is what happened to you. This is how you learn to cope with that or survive that.
Absolutely. So I know CBT sort of deals with sort of the individual's faulty thinking, but I don't believe, victims are faulty thinking. It's the abusers that are the faulty ones.
Yeah. So again, I think it's done with good intention, and I have seen that CBT. There are some elements of CBT which can be helpful, but it's again using an integrative approach. Integrative approach means that you are, when you're sitting down thinking about a treatment plan or a therapy plan, you're really thinking about everything, and not only you putting only CBT in place, because then the message the person is going to get is, so you were saying all these thoughts I'm having is unhelpful or negative. So something's obviously clearly wrong with my head.
Definitely.
That's one thing. So people often feel like a failure, especially when they have had been childhood trauma. You're already carrying that sort of negative view about yourself. So the moment you have got something wrong, immediately it's like, I'm wrong, I'm bad.
That's it.
So how are you able to engage with therapy when you're in that sort of state?
That's it. You're eternalizing it. You don't have a relationship with yourself because you're never going to build one.
Exactly.
And I know from research that I've read, people that sort of go to the GP with depression, anxiety, sort of eating issues, addiction, reliance, they all get sent, to the psychological services, and that particular issue gets dealt with. But sort of with a trauma-informed way, we would be more looking at why that was caused in the first place. Am I right in saying that?
Yeah. And that's also the neurological side, isn't it? Like you mentioned CBT. In order to do CBT or any sort of talking therapy, you would have to use the part of your brain which is to do with thinking and talking.
Yeah.
But when you are really scared or anxious or triggered, that part is going to shut down.
Mm-hmm.
So if somebody sits in front of you trying to challenge your thought, that's just going to become a vicious circle and more difficult to engage with. So, like
Especially if the behaviour is habitual, sure.
yeah. So I'm not saying CBT won't work, but it's about
Perfect.
how that's being applied, and it's also about what we call a phased approach to trauma work. So you wouldn't even go anywhere near CBT before you do the earliest part of work, which is about grounding, which is about becoming more comfortable with your body, work building resources before you go anywhere there.
Yeah, yeah. And in your sort of field, what could you explain what trauma informed care and practice is? Sort of what that approach is defined as? What I get comfortable.
Yeah, so like, sometimes people think, oh, they are two different things.
Yeah.
But again, there is an overlap, there it is an overlap. But
Mm-hmm.
if you really have to split them, trauma-informed care is more patients, it's more to do with patients. So think about it like hospital or dentist, GP. That's where they will use that term, trauma-informed care.
Yeah.
Whereas trauma-informed practice is more a wider term. So, even trauma-informed care is also trauma-informed practice. You can't have trauma-informed practice without trauma-informed care.
Mm-hmm.
But there are certain principles of it. So usually people say that trauma-informed care, you have to break it down to five basic principles, which is safety, creating safety. Safety is so important, isn't it, for people who have had trauma.
Mm-hmm.
So that's one of the things we are often lacking in when it comes to even say an appointment. There's not an advanced heads up that this could be actually triggering, that you're going to be alone in a room with somebody and might have to remove your clothes for a checkup, which can be really triggering. So that sort of things are never considered when we got an appointment letter through the door.
Yes, absolutely. I know myself, I'm absolutely terrified of the dentist. Oh no. Something about sitting in that chair in the middle of the room with
it's someone very close to you, right? And it's quite invasive, and you have no control. You sat there with your mouth open and people are doing stuff to you.
Exactly. And to tell them, oh, I have trauma, they think immediately the worst, but they don't really know how to put that into practice, tell me what you're doing first, don't come at me.
Exactly.
So my experience having had CBT and going to the dentist, things like that, it's been that no one really understood what trauma was, and it actually caused trauma in itself. And I'm not sure if that's because it was maybe 5, 6, 7 years ago and maybe things are changing, but how do you see the face of sort of appointments and GP and psychologist dentist visits going in the future?
Like at the moment, I think, there is a change, but we have to think that things like NHS, it is a large service, isn't it? And it's a large service, and change is happening, but it is going to be a slow change. It's not going to happen drastically. And I have some colleagues where they do work with like pilot programs within the NHS, and where they are trying to bring in people to do, say, movement related things or gardening projects together. And they're different. So there is definitely a shift there, that they haven't used the word trauma, but I think they are really thinking about it in a broader aspect, rather than it's just about changing a person's thoughts.
Changing how they feel within. And I really like the term adverse life experience rather than trauma, but there we go, that's my personal.
Yes. Again, that's a good point, because I think often the word trauma, people start to compare and think that, oh, I haven't had as bad trauma as this person. But everybody's trauma is trauma. But it's, again, that sort of, people start comparing and feel uncomfortable, isn't it? Whereas adverse experience might feel more comfortable.
That's it, a little less shocking. In your role, do you see benefit from sort of a multi-level approach? So not just treating the mind, but treating body, breathing as well?
Because you have to think where we store trauma. We don't store trauma in the part of the brain. where we use for cognition, talking and all that. We do store it in our body. And also we store, when it comes to subconscious stuff, like things we have blocked away, or things we can't even remember because it happened so young, like what you mentioned, it's so young. But also it's implicit memory. Implicit memory means memories our body hold. That sort of things we can't just use one level of work. It has to be multi-level. And that I know slowly there's a shift here, but like things about using body-based approaches like breath work, movement, even vocal, like, being able to even scream. Some therapists, trauma therapists do that sort of work. I do that sort of work where, if you didn't have a voice, let's imagine, you're going back to that moment and going to use your voice now. So that sort of thing where you actually work with the sensory experience as well.
And I suppose as well, every sort of individual would benefit from different approaches. Whereas one individual might benefit from screaming and verbal ventilation, another individual might, benefit from something else. So being trauma informed would sort of identify those needs and change the pathway of treatment.
Yeah, exactly.
A really, really great thing. Would you agree that the sort of blanket approach with the NHS is sort of CBT and EMDR?
Yeah, so again, I think there is an issue with that. The issue is that I think sometimes you hear the word trauma and think, okay, it's trauma, and they're not really thinking, is it complex trauma? Is it developmental trauma? And think about a treatment approach according to that. I think the biggest issue here with that is that often it's like trauma and right away it's like EMDR.
Definitely.
Or you have depression or anxiety or any other issue, addiction or eating disorder, let's send you to get some CBT. Absolutely. Not really thinking about what is the core of that, where does that even come from, and use that sort of trauma.
Imagine like hundreds of thousands of people. Imagine the amount of individuals in the UK that have went to their GP or a psychologist for depression or substance issues, eating disorder. I mean, I know myself, the very first time I went to a therapy appointment, I was 15, was for an eating disorder, but that was actually a manifestation of my sort of developmental trauma and my attachment issues. We potentially have hundreds of thousands of people in the UK out there that think, oh, I've got depression, I've got anxiety and everything's fine, when actually there's deep-rooted sort of relationship issues and things like that.
Exactly.
It's such a big lot. It's a lot of jargon and it's a big puzzle, but it seems like it's going in the right direction.
Yeah. I think that's the thing, isn't it? Like there's still so much shift and change needed, but I think that we are going the right direction. Definitely. People are starting to be more trauma informed.
So say that an individual was able to access sort of a treatment that you provide where it's trauma informed. Could you give them any tips or advice as to how to ensure that what they're embarking upon is trauma informed and that the therapist is aware of trauma in different stages? Is there anything that they could ask, just to make sure of that?
I think one of the most important first step is to educate themselves, to be more informed, because without being informed, you wouldn't, you often, I have had clients coming to me saying, oh, I saw a therapist before on the website, it says they were trauma informed. So I thought that means trauma work. So I think it's really important to educate themselves, like by accessing free resources, like you post a lot in your group, and joining groups and reading, and doing whatever they can to educate themselves before taking that step. And also, because I think once you are more informed, you're going to feel a little bit more in control, right? And you're going to also have the confidence to request specific type of help. Now, that's not to guarantee that you might get that help. You might not get, but you would be able to not blindly go in there. And it's not to say that NHS might not be able to help with that. But if they have to go private, then it's again the same rules to speak to the therapist to find out before even committing to therapy. You know, some people provide free consultation, some provide just like a phone consultation for an option for you to ask questions. And I think the sort of questions you're going to ask is to really find out is, are they trauma informed, which is great. You know, it's great if a therapist is trauma informed, or are they a trauma therapist? Because there's a difference there. Trauma informed means they are taking trauma into consideration. They have done a lot of learning, and they have that mindset when they're working with you as a client, which is amazing. But that it doesn't guarantee, and it doesn't mean that they have a set of tools in their toolbox when it comes to trauma treatment. You know, what they're able to offer you in terms of therapeutic intervention might still only be EMDR. So I think you have to try to find out, do you do body related work?
That's it.
You know, do you do sensory, anything to do with sensory processing of the trauma? Do you do work which is about things which might be unconscious or subconscious? Do you do work around that? So basically you finding out, just ruling out, is it only going to be talking therapy, or is it going to involve body as well? And if they said, you know, if the answer is that they will do body related work as well, then I think that, you know, that's great. And also phased approach, you know, that's another really important one, that you don't go right into trauma work. So again, if you haven't had enough training when it comes to trauma therapy, you might just think, oh, I have read a lot about trauma, I know a lot about trauma, let's process trauma, which can actually
in there.
that will just end up triggering and just make things worse. So it's about what's called a phased approach, which is really helping the client to build resources,
build that good foundation.
Yes, foundation before you. With some people it can take like a month. With other people, especially if they've been developmental and complex trauma, you have to do at least
years.
A lot of weeks before you're able to do that. Months sometimes.
Do you think location as well, like where you stay, do you think that sort of makes a difference? I've heard a lot of members sort of in the group say, well, I've had great help, but maybe it's because of where I'm from. I've not had that great help. I'm in Glasgow. Don't know if you can tell I'm Scottish. I've been through in excess of 10 different counselling blocks, like being referred, and have had minimal help from it. The only help that I've really sort of gained was through creating the group and doing my own research and things like that. But I was just wondering if it was where I am, my location, or do you know, is some locations better than others?
Yeah. In all honesty, I don't know. I haven't I'm just thinking any sort of trauma therapists that I have connections with in UK. They're all from different parts
different parts of the world and things.
Yes.
Maybe as sort of trauma-informed treatment builds and grows and research sort of becomes more available, then it may become everywhere more accessible.
Yeah.
Definitely. Do you think there's any additional research that we could provide to sort of help our growing member base? Because I mean, we know about trauma-informed care and we know about things like that, but what could I provide people? Do you think that would?
You mean the members in your group, or you mean generally?
Well, I'm trying to help everyone.
Yeah,
I love my members.
I think it's just for people to, like I said earlier, keep being informed and also fighting for your rights. I think fighting for our rights can be really difficult when we're a trauma survivor, because often we didn't have a voice or choice. But really fighting for your rights and say, this is not, even say, this is not what I'm in therapy for. I don't want to only talk. I want to work on X, Y, Z, or, I want to work on managing my triggers better. Being really vocal about those sort of things.
Yeah, and sort of being forefront about, because I think the nature of trauma, it sort of dissipates your human nature. You become a shell. And so speaking out for what you need is so important in recovery.
I'm just thinking, like, often people talk to me about how even before going to a doctor's appointment, that can be triggering, because it's that sort of power dynamic. And
absolutely.
Yes, it's again about
male doctors, female doctors. I mean, I can't even work because of the power dynamic. So
yeah, yeah,
it's really struggling. And I think with trauma survivors as well, we read, I mean, I think I can feel what other people feel. Like I'm a huge empath.
yeah,
And if a doctor is in a bad mood, could be with not had his lunch or whatever.
yeah, yeah. You pick on it.
Me, it's like, oh my God, what have I done?
Yeah, yeah, yeah. I get that. Yes.
So in trauma-informed care, maybe it's important for the knowledge to be available as this is how we feel, you know, we're really sensitive and we read your body language like a robot would, and so
Yeah,
doctors maybe get a little bit of insight and
yeah.
e-services, police and stuff.
And
Have
also
you,
doing some work before you even go in for those appointments, you know, like um, some sort of resource around that, like uh,
yeah,
whatever works for you to remind yourself that when you are sat on your own with the doctor or GP, that maybe there's a chance you get triggered, and you know, doing
yeah,
some sort of technique or grounding which works for you to remind yourself that they are not your abuser, you know,
mhm,
that you are actually safe in this, right in this moment. And
yeah,
that will be really difficult to remind yourself when you're triggered, so it's to help ground yourself in that moment. Whatever it works, you know, whether it's about taking a couple of deep breaths or whatever works for you.
I used to take in, I don't know if you know them, Dolly mixtures.
No.
So they're like sweets,
All right.
they can be foreign, basically they're in a bag and I would squeeze them like a stress ball, and I'd come out of the appointment and it would just be a ball of sugar, you know, and I just use them because I was so stressed out. I was like, ugh. But it helped, you know. It was my own cope mechanism. But of
Yeah.
course, what helps me is not going to help someone else, and that's
No.
the whole basis of trauma
Exactly.
informed,
Exactly.
you know. So further in the trauma informed approach, and just to sort of wrap the video up a little bit, do you believe maybe a trauma informed approach in schools, social work, police would be beneficial?
Yes, because it you know, people who are have lived through trauma, they're not only going to be facing therapy or hospitals, right?
Yeah.
They are going to, there will have been a time they were in school, there will be a time where the children will be in school.
Mm-hmm.
So you know, just think about generational trauma, you
Yeah.
know. So I think it's really important to, for all the you know, key services or professional services to be trauma informed.
Absolutely.
Definitely.
I mean, having a child in a class. I used to work in high schools and nurseries,
Okay.
primary schools, as a classroom assistant, and you know they have the sticker charts.
Oh,
If you're good, if you're good, you get a sticker.
uh,
So you take some of these ace children.
yeah,
You know they're clearly in the high end of the A scale, and
yeah,
they're like, "See you and your sticker. Tell you where to go with that sticker, because I don't like you."
yes,
You know, it's sort of including all of this, sort of how we discipline children, how we rear them, how we teach
yeah,
them. It would make so much difference. It would give so many
really,
children that have, I mean, school is now the safe place. We've took away like sort of the belt and punishment in the UK 30, 40 years ago, whatever. And people say, oh, behaviour in school's increased, it's terrible, bring back the belt, bring back the ruler.
yeah, yeah.
Actually, in fact, that's turned school into the only safe place some children have.
It's
So no
good.
wonder, yeah, no wonder the behaviour is going
Yes,
wrong.
yes,
So
yes,
maybe trauma informed in school is a
yes.
great start, especially
It,
going forward.
and I find it really, really sad because like I told you earlier, I worked in a trauma and attachment clinic, and part of that work involved uh, really close contact, you know, with school.
Mm-hmm.
And often I would have to go into school, or I would have to invite school into the clinic, and we'll talk about how a child's disruptive behavior or aggressive behavior is probably their fight flight response if there have
Yeah,
been developmental trauma, and really talk about it from a trauma informed perspective. Most of the time they don't get it. Sometimes they do get it, and we sit down and plan strategies together
yeah,
about how to manage that in a, you know, trauma informed way. But repeatedly, once they leave the meeting,
mm,
we're back at square one.
that's it.
And it's just so frustrating and so sad because it's like, why? Like there's just such a lack of understanding. And this is one of the things I argued in my doctorate research, was that I think as part of teacher training, this should be part of the curriculum.
Oh,
You know,
100%.
about children's trauma and how those children, it's not always only disruptive. Some children are just very people pleasing.
Associated perfectionist. I mean,
Yes,
perfectionistic child doesn't get,
exactly.
you
And
know, slapped in that. You're
yes,
perfectionist, you're the great student, but it's actually a trauma response.
exactly. It's people pleasing, isn't it? It's a
Yeah,
phone response. And
absolutely.
and how would teachers know unless they're getting educated about that?
Exactly.
And another thing is teachers' own triggers. Teachers are
Mhm.
human beings like you and me. They would
Yeah,
have a history. They would have their own attachment style.
yeah.
So the child's argumentative or conflict type of confrontational behavior can
Hmm.
trigger a teacher, and then
Yeah,
they are going to probably go into their own flight or fight, isn't it? So, and that's not their fault. How would they wouldn't know all this unless they had the training?
hmm,
And that's why I think really, really it's important that part of teacher training, this should be there included.
definitely. I think as well as part of curriculum, we should maybe teach emotional regulation. I
Yeah.
would say even more than math,
Yeah.
because like for some people, math never, you do math, you go out, you end school and you never use it again, algebra, whatever. But we always need self-regulation, and this just isn't being taught in schools either.
Yeah.
So interesting the place that this could go. This has no limits to
Yeah.
trauma-informed care. In my own experience of like inappropriate reactions from paramedics, from nurses, from police, and I just feel like if we could raise awareness about
Yeah.
trauma-informed practice, that cases of re-traumatization, it would reduce.
Exactly, exactly. And this is how I see it. I don't see this as police officers or
Yeah.
doctors doing a bad job. I just
No,
think
not
if I just think
misinformed.
they yes, they don't know. Like how
Yeah,
how how can we do something if we have no idea about that? This is
that's
how a person's behavior is if they're in a survival mode, you
yeah,
know.
yeah.
And it's that sort of education which is lacking.
In your opinion, what potential is there for sort of trauma-informed care to expand into the class and into police? Is there potential for that, and is it worth me fighting? You know?
Yeah, yeah, I think definitely worth fighting, and I think it's also about you know services like yours and many other charities even being willing to go into schools, going into
Yeah.
police for a day training. Like
Mm-hmm.
I recently contacted a charity in Sheffield dealing with supporting moms who have escaped domestic abuse, and I got in touch with that charity and said, asked the founder, shall you and me go into schools and offer training for the children to learn about the
Amazing.
kinds of toxic relationships,
Yeah,
because kids, if they get know early on what coercive abuse is and all that, they're going to be better informed developing
absolutely,
relationships.
absolutely. And
So I
one of the
think,
studies that I did run was looking at sort of the causes of trauma and bullying and things like that came out as number one, and it's nothing that I would
exactly.
have expected. I would have expected, as everyone would have at one point, sexual abuse, war,
Mm,
physical abuse, things like that. Bullying,
bullying.
yeah.
Yeah,
So there's such a need for this in schools. It's insurmountable.
yeah. And bullying, even the child who's bullying is probably carrying
Yeah,
their own trauma.
yeah,
That child is a victim as well. And
yeah,
often what school do is they do punitive, it's a
yeah.
punitive approach they take, which is just going to make things worse because the
Move
child
the
is going,
child to the front of the classroom,
yeah,
but then the child at the front of the classroom now has sensory overload behind, which
yeah,
then furthers the trauma response. It's
yeah, yeah.
we could talk about it for hours.
And how
Um,
are you going to behave in a good way if you're feeling bad?
no,
If you're already feeling bad about yourself, you're already feeling
stickers
bad.
won't work.
Exactly. So
So I just wanted to kind of wrap it up a little bit. I could literally speak to you for another good few hours. But I have a child baby coming back in like 15
oh,
minutes. So I just wanted to kind of wrap it up, and if you could sort of give your final thoughts on this.
Sorry, I missed the
Just
last part.
wanted to kind of wrap it up and see what your final thoughts were on sort of trauma-informed care and where you see it
Yeah,
going. And anything that you're working on, I'd like to
I
hear about it.
Yeah, I just think final thoughts, I will share it like if in terms of all the services, I just want to really highlight this is not a criticism of all the hard and amazing work you guys are doing, but
Absolutely.
that there is more need for a shift, and maybe it's for you to also argue or fight for that, to get more training in place, because there are a lot of people who are willing and knowledgeable to offer that sort of training.
Absolutely.
What I would like to say to any trauma survivors listening is that, I know that for many people it's financial difficulties which stop them from uh, receiving specialist trauma therapy. And I have been there myself, and I know that different therapists work differently. There are some which are very strict and say this is what I charge, no
Yeah.
flexibility. But there are laws who do differently. So it's about researching. Some people do subsided like fees.
Yeah.
Once a month they will allow that. Other people do what's called sliding scale. So they might say from 25 to 50 pound, and you can pay whatever suits you within that amount. Some people even offer free spaces, like to a limited numbers. I do that myself. Like I
Yeah, I
do,
think.
I do trauma workshops and all that. Where every time I run it, I offer free spaces and discounted spaces. So I know other people do that sort of things as well. So it's really about looking around and find some help for you, because it's not right that you sit at home and not able to get
Yeah,
help just because of financial difficulties. It's not fair.
absolutely. Well, thank you so much for coming on and giving me the time to talk to me about trauma-informed care. So I'd just like to say to my members that we, both Sharmi and I, are here for you. So if you ever need any support, please just reach out to us and we will help. Gotta say bye.
Bye.